Hello and welcome to my channel. My name is Peter Abraham. I'm a registered nurse with various experience, including extensive hospice and palliative care. I'm currently on the journey to become a certified end-of-life doula, sometimes known as a transition coach or a death coach, through the International Doula Life Movement, also known as IDLM. In this channel, we discuss topics involving hospice and palliative care, and various end-of-life topics, including grief, anticipatory, which is grieving before somebody passes away, the grieving process afterwards, hospice nursing topics, which is going to be part of today's discussion of what happens when you're handed a recertification that you've not seen the patient, including slow decline, because to me these can be hand in hand depending on the circumstance. And we also talk about writing books. I am an avid book writer. Three of the books that we're going to be talking about today, there's the #1 bestseller dealing with hospice documentation, meeting Medicare guidelines. There's the hospice eligibility in terms of admissions, but there's scales in here that also apply throughout the course. And then there's mastering hospice recertifications. So before we go much further, some housekeeping. If you like what you're seeing, please like. It helps the YouTube algorithm. This is a very small channel. Every little bit helps. If you like these type of topics, subscribe so that you get notified, especially if you hit the bell saying that you want to be notified with every video. I try to publish at least twice a week. Some weeks like today, this week here, 4 videos in a week, but that's more rare than not, but at least twice. And always feel free to comment. This is a non-judgmental channel. But before we get into that, moving forward, I like to encourage everyone coming here to do something I've been trying to practice for the past several years that makes a wonderful difference, building up resilience. Resilience is that ability to just snap back when you've been pushed down under. And we all get storms in our lives. Let no one fool you that everybody's peachy, happy, keen all of the time. Chances are high if somebody's smiling all the time, they're crying underneath the surface. So part of building resilience involves recognizing and asking, what are you grateful for, and making recognition of that. So as we come to a close of May, we've broke 700 books sold. Not just one book, but all the, I've written and published 53 books. If you go to Amazon, it'll say 55, but 2 of them are retired titles. And depending on your point of view, you may say that they're guides. They're not War and Peace. Some of them are thicker than others. But whatever you want to call them, guides or books, I just love writing and doing articles. I put out some free PDF files in some groups this evening dealing with the grieving process. So I'm grateful for every last one of you buying and reading the books that I've been publishing. I'm grateful for the vegetable garden that we started here in Kentucky. This evening my wife and I went and harvested one of several cabbages, close to 5 pounds, and my wife made cabbage soup. I'm weird, my favorite food is cabbage, and my wife is a great cook. So I'm grateful for that. And I'm grateful to spend some time with you this evening. So moving on to today's topic, I'm going to just deal with 2 pieces. Slow decline and what happens if you're handed, here's a recertification and you have not seen the patient before. So when we talk about slow declines, these are typically your neurological disorders, Alzheimer's, which it can be an official diagnosis, or you'll get senile degeneration of the brain. One of my picky points is vascular dementia is a specific diagnosis, but Medicare doesn't allow it. So if there's vascular dementia, they're typically under senile degeneration of the brain. They have mixed dementia, which might be Alzheimer's disease and vascular dementia, or Parkinson's dementia and another dementia. Those are typically under senile degeneration of the brain. There's actually a list of invalid diagnosis codes. But if you're having slow decline, number one, as a hospice nurse, what you should be doing, and I really love the words that, I don't know if Shelley Henry from the Anarchy Group is the creator of these words. I've used them in several of my books. I did not invent the word, so I want to be very clear, I'm not claiming ownership. But the research jot method, which is just taking very quick notes as you're doing your visit. What are the key things that you're noticing for decline? Brand new hospice nurses may focus on vital signs. Over the course of time, if you've not gotten there already, vital signs mean close to nothing. The very end, your respiratory rate and pattern and your heart rate will matter more, but most of the time the vitals aren't going to tell you, especially with slow decline. So what are you going to be looking for? What I look at, and this is where you take notes and try to have a good frequency of visits and try to be the one visiting, is, were they wearing a wedding ring and they can't wear it anymore because it just keeps falling off, or maybe they switched it from their wedding finger to the middle ring, or maybe you go one visit and they're like, where's the wedding ring? Oh, I put it on a necklace because it just doesn't fit right anymore. And the clothing is looser. And maybe you start saying to yourself, I need to take the MUAC. Some hospice nurses will refer to the MAC. That's the measurement around here. And be consistent in terms of where you're going on the arm. You should measure consistently. And I'm pointing to my left, but technically it should be the right unless they're missing the appendage. But use the same arm, same location every time. And maybe, okay, we're having centimeters of difference. All of these add up. If your gut feeling is this person is eligible, you should be doing everything you can every visit. Where are they going with this? We know they're heading to death, so I'm not trying to ask a trick question, but do you have to do the MAC? What about, checking the thigh? Or the lower calf. Get creative. Get creative. If you're starting to see things, are they gaining weight, for example, which would be, are they improving? Well, is this because they have liver disease? Is this because they have heart disease, so diuretics are not working as effectively? Or maybe it's the food that they're eating. But you're paying careful attention, you're interviewing the caregivers, you're interviewing the family members. Before I go on to the surprise research, because I want to keep this a short visit, a short video, is you're the detective. If you really, really believe this patient is appropriate, then go interview people. If they're at a facility, interview the CNAs are going to potentially know more than the facility nurses. What have you been noticing? I would do this 30 days out. I wouldn't wait until the research. Every visit I'm asking the caregivers, I'm asking, maybe if the roommate's with it, I'll take notes. Roommate shared, and watch HIPAA appropriateness as well if you're using, certain parties. But take notes. Where's this heading? How slow? What are you noticing? Are they taking more time to eat? Do they need to be encouraged? Like I had a patient that if you did not, like almost every minute, put it in your mouth, put it in your mouth. This is on us to be the detectives to prove the case. So in this book, I have a section on charting slow decline. And I also go over tips in the recertification book as well. Now let's talk about the next subject of this two-piece video. And this is something that came up today in the Hospice Nursing Period Facebook group for mainly hospice nurses. Sometimes there'll be patients and families there, but it's mainly nurses. And a nurse shared that they got a brand new recertification to do. The patient has Alzheimer's, and they've been with the agency on service for 4 years. So a couple things. If you're listening and you've been doing hospice nursing for any period of time, sirens and red flags should be going off in your head. Why are they assigning this to a nurse who's not seen the patient before? Why has this patient been on for 4 years? Now, in terms of some clarity, I wish we lived in a world of no fine print. We've had Jimmy Carter's case that proved, and I've had patients that have been on for 2 or a little bit over 2 years. But a couple things. One, Medicare starts looking, and when I say looking, I'm not saying that they necessarily come to, but the risk of being audited goes up starting in the 5th benefit period moving forward. So the 5th benefit period, you have 90 days, 90 days. Those are your first 2 benefit periods. That's your 6-month period. And then a qualified unlimited number of 60 days. The qualification is, again, through all of this, you have to prove that based on the documentation, based on clinical judgment, the medical director, based on their license, I certify that if everything goes according to normal plan, so to speak, the normal course of action, this person's going to die in 6 months or less. But 5 benefit periods is approximately 1 year of time. And so at that point in time, this is a slow decline if it's not self-evident by the 3rd or 4th benefit period. So 4 years, do the math, how many benefit periods that is. That's a lot. It's not going to be, just so you know, if 5 is 1 year, it's not going to be 10 is 2, because 5 includes 2 of the 6 months. So it's not going to be that easy. But after the first year, it's 6 benefit periods a year. So let's work backwards. The 4th year, 6 benefit periods were there. And double check my math because I'm doing this quickly in my head. The 3rd year would have been 6 benefit periods. The 2nd year would have been 6 benefit periods, and then you would have had the 5. So 4, 3, 2. 3 times 6 is 18, and then you'd have 5. 23 benefit periods. Oh my word. Siren should be going off. Why was this person even admitted in the first place? If you're that person that gets hit with this, first and foremost, if this is me, I am not going to be scheduling the certification visit until I review the face-to-face, until I look at the previous recertifications. What was their FAST scale, F-A-S-T scale on admission? Now, if they only have Alzheimer's, the best FAST scale for an admission is 7C. Medicare allows for 7A, but in terms of being as appropriate as possible, if all they have is Alzheimer's, 7C is the safest admitting point. If they have comorbid conditions, and in the form somebody did put 6E, I have had those cases where they're handed to me, and I try to work with them. But to me, that's playing with fire. I'd rather go with 7A with comorbid conditions. But what was their FAST scale on admission? What was the FAST scale progression over those 4 years, including the previous recertification? And what were the reasons why this person passed the previous recertification? Now, me personally, in the best detective work, if you had all the time in the world, I'd go back and look over every recertification from the beginning. But in the real world, we have too many patients to see and too much pressure. So I'd be trying to work to get that information together, and I'd actually say to the team, I do not feel comfortable doing the Recert visit until I have all the evidence. And this might be a compliance issue. And me personally, and I'm not telling you what to do, you do you, but me personally, if I got pushback saying I had to certify for, and I've had cases like this, I would tell management, I'm calling compliance and I'm calling the Medicare fraud line. You're going to have a decision of what you want to do. You're going to have a decision of what you want to do. And maybe your scheme of things is I get fired or I get written up. And yes, these are harsh realities of where we're at in life. But I have boundaries, including professional boundaries. I have ethical boundaries. I am not going to engage in Medicare fraud. Sorry, not my case. And in terms of, and this will be a small rabbit trail, I had a case that I had to fight for in terms of getting appropriate discharge. The patient was only admitted because the group home said that without hospice, the person could not have a pureed diet because their dysphagia was so bad. Without hospice, they would force, I don't know if the force is the right word, they told the family the person would need a feeding tube in order to remain in the group home or be on hospice. And for lack of better words, the family found a social worker, and I'm not saying the social worker was wrong for caring, but felt so strongly for the family it was like admit the patient. And at first it actually seemed like it might be an okay admission, and this is one of the slow ones when you're having these slow admissions. This person had neurological disorders. But as I'm the nurse seeing the patient, the ADLs, they didn't need too much help with the ADLs. Yes, they were incontinent of bowel and bladder. They were not senile degeneration of the brain. This goes back years. It might have been protein calorie malnutrition was what they used as a diagnosis. It's not one of my favorites because it's the easiest one to get discharged from because all you have to do is gain weight, and then your medical director will go, well, let's get the pre-albumin, albumin, and total protein, and if it's just shy of abnormal. But I'd be like back to our nursing boards, 0.1 off the lab values. I'm sorry. That they wouldn't even ask that on the nursing boards. You have to be significantly abnormal to be end of life if you're going to go with the lab values for protein, calorie malnutrition. But that person ended, I advocated that this was not the case. I advocated for the family caregiver. You got options. This group home was doing unethical procedures in terms of trying to force the family to get a feeding tube. Are you kidding me? We don't live in this type of world, or we shouldn't. Maybe we do, and I'm the delusional one. But that's it for these two topics. As I share what I'm sharing, from a point of view, I have a level of expertise. I have trained hospice nurses. I have been a preceptor for hospice nurses. I have trained nursing students. This particular book, Mastering Hospice Eligibility, if you go to Amazon.com and you can see what the back cover says, Dr. Andy, I'm not going to try to pronounce his last name, gave such a blessed testimonial to this book. He's a hospice and palliative care medical director. He is on LinkedIn, and the actual link to the quote on the back cover is still up on LinkedIn. But he said that all the medical director should have this book, the admission nurses should have this book, IDG members should have this book, because, and this is going to be a plug, this doesn't just deal with like the quick flips that is how old, that just goes over local coverage determinants, that's in this book, but it also goes over what about those cases like sepsis or fractures, stuff that there's not an LCD for it, but they're still terminal. How do you admit the patient? So that goes over that. And then there's the hospice documentation and so on. But even so, as I share what I've been sharing, I have expertise, but I don't know it all. You might be seeing this and saying, but Peter, please do. Please comment below. I'm not going to argue with you. Maybe I can learn from you. I appreciate comments. I appreciate dialogue. I thank you for watching. God bless and goodbye.